what I'm going to do today is just a brief introduction about the technology, how we ended up using this technique. Um, so we started our first trials doing non-invasive PGT-A several years ago. As you know, there is nowadays like two alternatives to use non-invasive PGT-A. The first one is to use the spent culture media to measure the DNA that the embryo are releasing to the culture media. But at that time, it was 2016, we put our attention on this, on the blastosynthesis. This was in the in 2016. In this Congress, we decided to try to use non-invasive PGT-A, again, based on blastosynthesis, mainly, to be fully honest, because we were having a lot of problems to find embryologists doing biopsies. So we were thinking that probably moving to non-invasive will be easier for everybody. So we went to this course on blastosynthesis in the Giannalonis lab, and then when we were there using blastosynthesis with microarrays, you know, in this lab, in Giannalonis lab, everything works perfectly. We had very nice results, so we were like very optimistic about that. And then we started our collaboration with one clinic, with Dr. Blöke, trying to implement blastosynthesis. But, you know, whatever worked in the Giannalonis lab didn't work in my lab, didn't work in my hands. So we were dealing with this like 1 or 2 years, trying to improve the protocol, trying to improve many aspects of the blastosynthesis, but it never worked. So then we moved to the spent culture media. We found at the beginning the things quite easy with the culture media because we had enough DNA to do amplification. We were able to have what we thought that were good profiles, but the problem is that we had all the time these kind of profiles, meaning that we were analyzing the DNA, the maternal DNA, the DNA of the mother. So we were like obsessed on how to fix this, how to remove the maternal contamination, and we tried many different things. We tried the use of preservants, things that we were thinking that probably will fix the DNA of the cells of the mother and then didn't release this DNA to the medium, didn't work. We tried to purify to separate the maternal DNA from the fetal DNA. We try also to take the advantage of the different methylation pattern that was observed between the maternal DNA and the fetal and the embryo DNA. We try also to do some sophisticated bioinformatic analysis for the same reason, to separate the maternal from the embryonic DNA, and many different things, but never work. I mean, I would like to say that we learned a lot of things, but it's not true. We just failed, and then we were, you know, a little bit desperate because we didn't know how to make it work. But then in 2020, Carmen Rubio and her group published these results with a good correlation between trophectoder biopsy and the culture media. And she had a very, you know, clever solution for our problem, that was to say that it wasn't the problem of the genetic lab, it was the problem in the IVF lab. So they suggested some modifications in the procedure in the IVF lab to get good results and to read out the maternal contamination. Fortunately, at that time, we found some people willing to try this with us, Albert and Peter and Kirsi were one of them. So we worked together very, very hard just to implement everything here, just to get good results. So at that point, the modifications in the IVF lab that are recommended to make it works is the first one. We need to do a denudation of the oocytes, quite extensive. Also, one important thing is to do the washing and change the embryos at day 4. With this, we remove all the maternal contamination. And then usually it is recommended to extend the culture on the day 6. Obviously, to culture the embryos isolated. You can do or not hatching. You can store the samples at -20. Obviously, it's important to use negative controls and to take a lot of care to avoid contamination from the staff in the IVF. So the first thing to do is a validation study in which, if you want to implement non-invasive, is you have to validate your results. And for this, you have ideally to compare your profiles between the trophector biopsy, which is the gold standard, as you know, with non-invasive with the culture media. So when we look at when we do the validation study, we look at many different KPIs to see if it is working or not. The first one, and one of the most important, is the amplification failure. Obviously, when we work with non-invasive, we expect to have a little bit higher amplification failures because we have very low DNA, very low amount of DNA. But again, it's not so high, so usually we expect to have 10% of amplification failure or lower. This is the expected value in red. In blue, we have you have the results that we are having with different clinics. So the second thing is that we look at the sex concordance between trophector biopsy and the culture media. Obviously, ideally, it should be 100%. It's not always like that, but we have to be close to 100%. If we have lower sex concordance, means that probably we are having maternal contamination. Then we look at the concordance in classification. That means that when we have a profile that is abnormal in trophector biopsy, for example, then we should have abnormal results in culture media, not paying attention about the specific aberrations we found, just normal, abnormal. And then what we expect to have is like at least 80% of concordance. Then if we look at the karyotype concordance, meaning that looking at the very specific aberrations we found, the concordance is quite low, but it doesn't matter. The important one is this one. Also, we look at the number of female embryos. Obviously, we expect to have around 50% of female and male embryos. If we have if we are in the high range of female embryos, usually means that we are seeing maternal contamination, and also the percentage of abnormal embryos, which obviously depends quite a lot on the patients. But if we are working with patients with advanced maternal age, usually we have around 70% of abnormal embryos. So with all the validation studies that we were performing during these years, we learned a few things. We learned that there is a lot of things that are not affecting the results. So we are not seeing differences between doing hatching or not. We are not seeing a lot of differences between extending the culture until day 5 or day 6. The ideal situation is to extend the culture until day 6. because we have more DNA in the culture media, so we have lower amplification failures. But in day 5, it works very nice also. There is no relation with the quality of the embryos. Good quality embryos are releasing enough DNA to perform the results and to get the results, and poor quality embryos are doing exactly the same. The type of the aneuploid is not affecting, and also the maternal age has nothing to do with the amount of DNA that we have in the culture media to perform the analysis. The only thing that is affecting is the IVF center, is the protocol that the IVF clinic is performing. So just to finish, what we think about if non-invasive PGT-A is the future. Well, we think so. We are quite confident that in the hopefully near future, non-invasive will be used in many clinics. First, because the changes that we propose to implement in the IVF center to make non-invasive works are not affecting the results in the IVF clinics. The results in the IVF clinics are exactly the same. Then also because very recently have been published a couple of papers showing that when you look at the concordance between the culture media and the inner cell mass, the concordance with IVF centers that are validated is around 90%. That is exactly the same concordance that we have if we look at trophectoid biopsy and inner cell mass. So that means that probably if the things are done correctly, the trophectoid biopsy represents the embryo as good as the culture media. But again, still some improvements in the protocol are needed because, again, we don't have 100% of concordance, especially when we look at the sexual chromosomes concordance. We need to have 100% there, so there is still some room for improvement. We need to find ways to identify the maternal contamination because when we are having a normal female embryo, we still have some doubts about if this is real or is maternal contamination. So we need to set up methods to identify maternal contamination. We need also to perform PGT-A and other SNPs-related tests. For example, the test to detect triploides embryos that are based on the SNP analysis. We need to find a way to do this non-invasive because nowadays it's not working very well. And also one very important thing is that we need to clarify how to report the results of non-invasive to the patients. This is quite important because what most of the IVF centers and genetic labs are doing, including ourselves, is that we are using non-invasive as a prioritization system. When we have the results of non-invasive, we say that this embryo should be transferred first because this embryo is most likely to be euploid, and then embryos with aneuploidies, culture media with aneuploidies, are selected as a second trial to transfer because the probability of being normal are lower. So we use non-invasive as a prioritization. But maybe this doesn't make sense at all because at the end you are saying abnormal things. So we are saying aberrations in the culture media. So how do you inform your patients? How do you say, okay, we are saying these aberrations in the culture media, but you can try. So we need to decide if we want to still using this prioritization system, or if we are confident enough in our results are good enough to say that an abnormal culture media should not be transferred. So that's all from my side. Thank you very much for your attention.